name is my name is Emilia Andersson. I'm an oncology lead in medical and government affairs team for Roche. And we are very, very delighted to be able to support these educational workshop series by CADQAS, which is basically a wish list where we just ask for really interesting markers to be discussed. As usual, the workshop will be led by Corrado and today together with Adelina Baltan. And we will discuss the Kappa Lambda dual-ish staining. If you have questions, you can either raise your hand and speak up, or you can post them in the chat, and we make sure that they are being addressed. So with that, please, Corrado and Adelina.
Thank you very much. And we thank Roche for sponsoring this session. We had arranged for Teresa Marafiotti to be also online and to help us presenting these cases. Unfortunately, she's down with the bad flu, so very likely she's not going to link in. However, I have prepared some nice slides for her, so I will show you in any case. Because Teresa and I, so this is the agenda. So we're going to have a quick brief introduction about clonality in hematological malignancy and the way in which we can look for light chain restriction. And then we're going to talk about this high sensitivity dual plex Kappa Lambda. But I want to very, very quickly get to the bottom of it because Adelina has prepared a lot of cases to discuss together and show stains. So that's the kind of crunch of it will be that. So Teresa Marafiotti and I come from this little corner of the world here. And she sits in Italy and I sit in Sicily, just opposite, and there is this Strait of Messina. There's a photograph from the plane. And if you go to the top of Mount Etna, which is a nice place to ski because you can then go and swim in the sea, you can actually see Italy from the other side. It's kind of a fantastic place. Anyway, Teresa and I have known each other for a very long time, and she will very likely join us for the feedback session, and I'm sorry that she cannot be with us for this session. This was a fantastic meeting. Ada and I were at this meeting in London. There were some incredible speakers and hematopathologists from all over the world. This was to celebrate Professor Peter Isaacson that will be here somewhere, but I cannot see him.
Neither to be.
Okay, never mind. Okay, so let's talk about clonality in hematological malignancies. So it's interesting to reflect that clonality is not a very established concept in the evolution of the thinking of oncology, but it emerged quite a long time ago because hematological malignancies were composed by cells. Very often they were all the same. They look very monomorphic. So the thought was they all come from the same kind of mother cell, and that's why the concept of clonality, which then eventually was transposed to solid tumors eventually. And you may or may not be surprised to know that the first evidence of clonality was in Hodgkin disease, and it was done using cytogenetics. Now, all of the things that we are talking about will always be surrogate markers for clonality in many, many cases. And you may or may not be surprised that one of the first reports on the use of immunohistochemistry was to assess light chain clonality in then plasmacytomas in 1974. You weren't even born.
Yes, about 20 years before.
And the first reports of T-cell receptor clonality came back in the mid-80s. Now, the reality of life is that the greatest majority of lymphomas are actually made up by identical clonal population. They have rearrangements of the B cell receptor or the T cell receptor. So the B cell receptor, which is also secreted as an immunoglobulin, is here, and the T cell receptor is here. They're all kind of similar. You see, they have variable regions and constant region. They are two molecules paired together, and then rearrangements in some of these areas, genetic rearrangement, make up the antigen recognition site, and the same for the antibody, so that you do end up with a very, very unique antibody because it recognizes a unique antigen in a unique way. So it's kind of possible that two different cells will come up with the same rearrangement, but it's kind of very rare, and certainly not for a large non-monoclonal population. However, it's kind of difficult to provide evidence that the antigen recognition site is unique, because you need to go and sequence each one particularly. But the byproduct of this is that at a certain point, cells choose to use a kind of variable region that is called lambda or kappa, and the same thing happened for the variable regions of the T cell receptor. So if you look at whether cells express kappa or lambda, and if they are there is a balanced expression of it, you kind of say that it's probably polytypic. And if there was only one type, you say, oh, that's kind of monotypic.
Yeah, and probably this is a more adequate term to use, because it doesn't assume that it's the same
because we are not sequencing things. We're just saying the whole variable region is the same. Okay, cool. Let me go on the next slide. So if you look at the pattern of the differential pathways of the B cell, the B cell starts to make up surface immunoglobulin, essentially the makeup of the immunoglobulin at this stage, at the pre-B cell stage. And once he leaves the bone marrow, he has chosen his variable region. So anything before that is kind of, that's not the right tool, but most B cell lymphomas are coming from after that. And then, of course, there is a shift in immunoglobulin classes from M to D or G, or et cetera, but the variable regions are fixed. And actually, I wanted to tell you, there have always been various ways in which to establish clonalities, either for T cell or B cell receptors. So one very established is flow cytometry. Flow cytometry is great. It gives you an idea of how big are these cells, and you can also use different markers. So you have multiplex.
Excellent to look at cells using.
And you get these scattergrams where size and then other markers are also very possible. But intrinsic to it, you need to have a fax machine and a workflow for fax, but that's fine. But also you need to have fresh tissue in effect, because you need to dissociate these cells, and then you have to incubate them with some antibodies or some probes of various size, and then you have to fire it through the machine. Doable. Some people have done also by dissociating from formalin fixed material. It's a big kerfuffle. But in reality, apart from UCL, I never worked in a place where something like this was available. So in effect, it's nice, but it's not for us, not for the majority of people. So another traditional way is polymerase chain reaction of various sorts. It doesn't matter, but again, you need to grind it, extract, and then you do something and may run gels like this, but it doesn't matter how you do it. But then you establish that there are a lot of signals from kappa or a lot of signals from lambda. And hence why, even in this situation, we started to talk about ratios. We know that if there is a ratio more than 4 kappa to 1 lambda, then it's probably a monotypic situation. If there is a ratio of more than 2 lambda or 2 lambda and 1 kappa, it's a monotypic situation for lambda. That's because you couldn't see the cells. These are that's overall population. No? But the things change a little bit when you examine in situ, and these are the two techniques of in situ examination. One is immunohistochemistry, and And 1974, can you imagine? 1974, this is one of the first deployment of immunohistochemistry, and these were rabbit polyclonal antisera. And look how beautiful these pictures. Obviously, they are plasma cells. Obviously, the signals are very good, but this is negative for Kappa and positive for Lambda, or vice versa. I can't remember. It doesn't really matter. And this is one of my heroes of all time, David Mason, who was a pioneer of the whole immunohistochemical field. So obviously, you see, the world was in black and white before these were the publications.
Yeah, even later than that.
So of course, later on, there were better technology to look at lower expression. So you see here, this is a paper from 2010, where you can actually also see signals in cells. These are follicular center cells, lower expressor of the signal. And these are really beautifully clean immunohistochemistry. I mean, anybody that does Kappa and Lambda know that they would die for an immunohistochemistry like that. And you end up, in fact, struggling to try and understand the good signal from the background signal, because the interstitium is full of immunoglobulins, and they will, after being fixed, you will pick up. But you can see that in theory is very possible. In practice, even at UCL, the Kappa and Lambda antibody stains was not working very well all the time. You were doing it. If you were lucky, you could interpret. If not,
Plus, it mostly applies to when you have like full differentiation to plasma cells.
Yes, when you have full differentiation, it's easier to interpret, but you can see now that the sensitivity is good enough to look at lower level of expression. Okay, so, and then the second in situ technology is in situ hybridization. In situ hybridization in general is a short probe that hybridizes to either DNA or RNA. In the case of Kappa and Lambda, everybody uses hybridization to the message because there is more of it. So there is a denaturation. You open up the strands, you hybridize the probe, and then somehow the probe is labeled with dozens of different technologies. Here there are some of them are clever, and some of them are very amplified, etc., etc. So there's a lot of different way of doing in situ hybridization. And in fact, there are lots of different kits on the market. So, and here are three. Probably this one is quite famous, the ACD Bio one, where there are these unique probes that sit next to each other on the tissue section, and then they are ligated, and then they're amplified by certain means, and they're quite sensitive. But the reality of life is that although these things have been, I remember ACD Bio came out in 2008, 2009. In very few centers use this technology. And the kit that we are exploring today is a kit that Roche has commercialized now. But if you see here, the original publication was 2014. And before you go to the publication, it would have been a few more years before that. Well, what I mean is that from 2014, this thing came out a year ago, 2 years ago. So there is a lot of development to make it stable, easy to use, plug and play, etc., etc. And this is some data you can read here. But in any case, you can show that this kit, like any others, because all of these other kits I showed you before, they have the same performance. But the reality is, and some of them use, like for instance, this one used the bond. It's been set up also for the use of the bond. But in reality, it's not pervasive. The use is not pervasive. And I don't know whether it's because it's difficult to set up, there is no assistance, or because it's not as good in clinical practice as the ones that we are proposing today, which is this one here. Okay, let me skip some of these things to say the chemistry of this kit is that you have some probes around 80 bases long that hybridizes to messenger RNA, either Kappa Lambda, and then there are amplification systems that result in either a silver-based stain, which is usually more sensitive and easier to interpret and tighter, or a dynamite-based magenta stain, which actually now is quite good. This is for the lambda probe. So when you interpret the stain, remember lambda is magenta and kappa is silver. Is it? No, this was the original paper.
This was the, yeah.
This
now
was the original paper.
Swap.
Now it's gone the other way around. And I think probably we will see why. Okay, so a few things to discuss. First one is that there are transcripts which are classed because they have homologies with other things, and this particular one is an immunoglobulin lambda-like polypeptide 5, which has so much homology with the lambda probe that if there is this signal in the nucleus, you are going to hybridize to it. There's no other way around it. So we need to understand what does the stain for IgLL5 look like, and therefore it helps us interpreting it. And here are two examples of a little bit of staining, and these are nuclear stains. So the transcript is we don't really know what this protein does. The transcript is a nuclear located transcript. And it is hybridizing therefore with a silver dot because you essentially cross-react with the lambda probe. But you can see here there is a large dot and it's nuclear-based. And here is a situation where most of the cells have got this transcript and is again high density. But you can see the difference. In this case, there is a kappa restriction in the cytoplasm, which is where you should see the signal because you're looking for message. Okay, so here are examples of another problem, and the other problem is that a very few lymphoma, okay, not a very few lymphoma, so some cases will show dual staining in the same cell. Some of it is possibly that is an artifact, but some of them are genuine, and about, well, less than 5% of lymphoma actually do express both chains.
Which shouldn't be surprising because
tumors are tumors and everything can happen.
We can even have biphenotypical, like BNT.
And as it happens, everybody is, because we're all pathologists, so now we identify two staining pattern A and pattern B, where cytoplasmic kappa and lambda, and pattern B is where the the one lambda is cytoplasmic and kappa is nuclear. Not entirely sure whether this is the result of some entrapment of the kappa probe in the nucleus rather than being truly biphenotypic. However, this is an example of a case that has got two double stain. Here is the duplex, and then if you also probe it with a single probe, you can see that cells have both. In this case, both. This looks nuclear to me, and this is cytoplasmic. Okay, so here is our example of pattern A, and this is an example of pattern B with nuclear staining. These are cytoplasmic staining. Okay, so I think in general, that's kind of the message, and I feel now we should try and see how do we interpret this staining. This is a little picture that I found while I was trying to prepare for this presentation about 5 minutes ago, because I thought it had an interesting thing, which is this one here, and I never really thought about it, but actually is kind of good thinking. And they were saying that if you, by any chance, have a case where there are cells, you don't know what they are, but they do not have Kappa and Lambda. This is classic Hodgkin. And in fact, lymphocyte predominant has got has got a Kappa or Lambda. And the other thing that I never really thought about, if you are thinking you have a B-cell lymphoma, because sometimes they express odd markers, B-cell markers. Yeah, but there are no signal for Kappa Lambda. I think this is probably a B-cell lymphoma. Okay, this is a rare thing, but I was thinking about this is an interesting lateral thinking.
What I'm not very sure is if B-cell lymphomas can be null, I guess.
Yes, but then you get into the proposition is what makes it a B-cell lymphoma if we cannot show any B-cell property.
But at least it helps you show that there's an abnormal architecture in
absolutely. Yeah. Okay. So the kit contains a reagent for reassuring that there is integrity of messenger RNA. I think this is a problem that we experience in the world of histopathology. Messenger RNA are relatively labile, and if the preservation is not very good, we may not actually stain very much. Because the tissue hasn't got the right RNA. So this is a ubiquitous signal, which is called U6SN RNA. Adelina will tell us what it stands for.
I think it's small nuclear
RNA. And is the kit as a probe, you can use it, and if you can show that there is nuclear signal, then it means the RNA is preserved. This is an example of preservation, and interestingly, it's a nuclear staining, so you should not see cytoplasmic signal if you use this probe.
Yeah, I've just been to a meeting, and I can see their labs that run on all of the cases that they're
all the time.
They're supposed to do in situ hybridization. Would you think you would run it before, or if the case has issues, or you do the stain and then...
This is an extra slide you need to run. So you are doubling you are halving the capacity of your immunohistochemistry lab if you run these things all the time. So we run it when we smell something is wrong and we want to understand why. But I understand that some people would do it up front for everything. Okay, so this is what I was telling you before. This is the convention. More than 4:1 ratio or less than 1:2 ratio mean restricted, and in between is not restricted. But that was at the time where we were grinding and getting a soup out of it. Now that you can actually see, you keep the context, it doesn't really matter because you are going to look in the region of interest for the cells that you are worried about, and you want to know whether those cells are monotypic or polytypic.
And this is the advantage of the tissue, right? Because in certain clinical scenarios, clonality is not really...
And by the way, we have not even discussed the fact that even if we demonstrate clonality or monotypic, it doesn't mean there is a lymphoma. Lymphoma is the result of a lot more things. You may at the end say there is a clonal expansion, perhaps, of a particular type of population of cells, but there is still a long way to make it into a disease. And vice versa, even if you cannot demonstrate clonality by this method, you are not going to shy away of the diagnosis of lymphoma if everything else points to it. Okay, so let's talk about controls. On-slide controls, I think you should use any well-preserved lymphoid tissue you are familiar with. These are tonsils. There is always the same discussion we have in tonsils. You need to fix them well and use long processing. Otherwise, the tissue is not really suitable for a lot of these analyses. You can see here at low power, you should get both signals. You should be able to see low degree of staining. So low degree of staining would be in the mantles, for instance. You should be able to see at times 10. That would be a good demonstration in your control. I think you have capture it is at higher power.
This is higher, but not very high. It's
Not
about
very, this
5.
could maybe times 5. And here you see that there are cells that stain very strongly. Obviously, this is a normal tonsil, it's a reactive tonsil. There is a polyclonal, obviously, response. And the dark staining cells are plasmacytic cells, even here. But you can see that in the centrocytes, maybe centroblasts, I don't know, there is still signal, and I can see, okay, I'm a little bit, with a bit of effort, I can see black dots and red dots, and I'm sure you have a high power, yes. So you can see here that the single small lymphoid cells, they express one or the other color, yeah? And then there are these strong dots that are most likely plasmacytic cells. And then, of course, you shouldn't get any dots in the areas where there are no B cells. Pretty clearly. Okay, so these are more examples of normal studies. So Adelina has collected lots and lots of case studies, really mostly none of them are lymph nodes, because we found that the major application of these is in the small biopsies like skin or GI tract, where first of all the biopsy is small, and secondly we have never really managed to provide a firm diagnosis of anything because, or let's say marginal zone, because we lacked evidence. But now this has given us impetus to say, well, actually, after all our beautiful immunohistochemistry, there is also evidence of monotypic population of monotypic B cells, so it's a much firmer diagnosis we can make.
So obviously the most useful is in this marginal zone in particular, because we don't have a marker, but other small B cell lymphomas as well.
And then as it happened, okay, it's a nice tool, we like to play, but as usual, you need to use it for all the cases that are easy for you to interpret, because you need to gain confidence whenever you want it for a particularly tricky case. So that's why probably
there is an element of play here.
There is an element of play, but the play is to understand how to interpret these things well. Okay, so that's the first case. I don't know.
So this is it's just to show, because we have, especially dermatopathologists, often in certain lesions, whether they are in skin or somewhere else at extranodal sites, you get this heavy infiltrate and while it happens that you have a lymphoma and a carcinoma next to each other, they're often rich, especially in the skin, and plasma cells. So you see this heavy infiltrate that is mostly consisting of plasma cells. And then you can think, oh, what if there are B cells maturing into plasma cells? So this is the dermatopathologist actually asked for a Kappa Lambda. And because we were in the early days and he wanted to see how it looks like. And this is how, because they're plasma cells, obviously we have a very high level of signal, and sometimes you can see it over the nucleus as well. So what would you say the ratio is? Is it kind of have a little bit more kappa?
Probably quite a bit more kappa. I think maybe.
So maybe 2 to 1, or.
Yes, maybe 3 to 1, 2 to 1, 3 to 1.
Yeah, it's kind of, I mean, they make a nice contrast, but it takes a while until we get used to.
Yes, but I think this is an example of polytypic response. Yes.
So that's
so in this case, and I must say, some of our dermatopathologists are a bit spoiled because there was no real overt worry about the cytology of these plasma cells.
But attention, they can be very bland. They can look like.
Okay, so that's
cells.
Okay, that's a
so
higher
this is
power.
the higher power. Yeah. So you can see it's quite crisp, especially in cases like this where you have. This is another.
We have a comment here just because you commented on the ratio. Do you have an approach to estimate the ratio?
So no, not really. I think that ratio concept is a concept that came from PCR and other technologies. But now I think you should look at the distribution of cells and look in the areas that you are worried about. And I think what Adelina showed you in this previous picture, you see these are uniformly mixed, you know, so this should not be worried. Yes, you can also, you know, be by standardization, do the ratio, but I'm not entirely sure how much you would be worried if the ratio came up, I don't know, 5 to 1.
5 to 1.
Would you see, oh, must be a plasmacytoma?
I think Corrado makes a very good point with this. And if you really want to, I mean, I would look at the smaller unit like a cluster and see, oh, okay, maybe they're mostly red ones, which we would expect because in reactive infiltrates we have mostly Kappa response, but there's obvious black signals in between. But you can, it's just visually, you can see.
I think, I don't know, Emilia, if you have a methodology, but I think if you a low power feel that this is the pattern everywhere, then you go a high power, and then the higher the power it is, the more you can isolate the element and you can get that proportion in your head, I feel.
I would agree, because I have the same approach, that I have the overview pattern first, and as you say, it's very equally distributed, so it's not worrying. But if I need to count, I usually go very high power and I select like a representative, what's the worst area where I would have, and then a more normal area to see what's the highest ratio I could achieve. And obviously it will then be less if you see it more in there.
Yeah.
But only counting a very small area.
Cool. Okay, so this was the second case you showed.
Yeah. So this ended up looking like as a slightly polypoid, but the infiltrate is mostly around the vessels.
Yeah.
Really looks reactive, but I put this one just to show you that sometimes. So this, I think it was a mixed infiltrate. So again, this doesn't mean the test didn't work, probably because it's reactive. Then you have other cells, histiocytes, lymphocytes, other types of cells, and then you see the plasma cells. So you don't see an intermediate kind of expression in this. And this was just to show that it had pigment and it had dead cells. So it's probably a regressing lesion. Okay.
Okay, that's a more worrying nodule in the skin, you know?
Yeah.
It's kind of vaguely nodular.
The other thing is in the skin, it's almost like they never suspect these lymphoid lesion. They're usually mistaken for something else.
Yes, they come with a different diagnosis. And so it's vaguely nodular. It abuts epidermis, but probably doesn't infiltrate it. And I don't know if we have a higher power.
Yeah, we should have.
Here we are. You see, it's not epidermotropic. And he's got these intermediate, small to intermediate cells.
Yeah, some of them, they look quite pleomorphic.
Well, this is the thing. The moment you start looking at the shape of the cells, everything, you can make it slightly atypical, even if not. So,
but if we're to compare with the small lymphocytes, so these are reactive.
Yeah, so you can see that there is a slight nuclear elongation, perhaps, and slightly abnormal nuclear outline, etc. But could go anyway.
Yeah,
this
I
one
think
here.
there are
So
other images that are
other images, yeah.
So, yeah, this is the same kind of cytology. I thought they were medium sized to large, really.
Yeah, medium, yeah, maybe.
And we can see because it's quite a lot of signal in some of them. It's predominantly dark at.
Okay.
So
here is there is a lot of lambda here, and certainly the cells with a lot more RNA are essentially all lambda, which is a worry. And then there are these cells in between. Do we have an higher power?
Yeah.
Yeah.
So again, I was trying to compare. Yeah, I guess if you compare to an endothelial cells, I don't know. Yeah, they're more like medium size.
These are endothelial cell nuclei, and these are intermediate size.
And we get weaker and smaller, smaller signals with Kappa. That is magenta.
Yeah. And so what do you think of this type of picture? Would you be worried now?
Yeah, I think is lambda restricted.
Yeah.
And yeah,
And then of
this
course
one,
we're not showing you all the other how
Yeah.
these cells stains, but
this was regarded, to me, the cytology is not very clear, but it was regarded as primary follicle center. So obviously had like follicular meshwork,
and a BCL6 perhaps.
BCL6 positivity,
Rather than
CD10 positive.
well, maybe not because it's the skin and therefore maybe CD10 negative, but it would not mark for markers that would exclude it, and it would be CD5 negative.
But this is quite a small kind of sample, and it's very useful to see the restriction.
Yeah. Okay. Don't know if there are any comments. That's another case. Punch biopsy, and this again looks worried, but this could still be an inflammatory dermatitis, really. Bit heavy going. And
the infiltrate looks a bit is interstitial and along probably
along the vessels,
spaces, the vessels.
Yeah. And here is the silhouette of the Kappa and Lambda. What do you think?
There's a lot of red,
magenta,
a lot of kappa.
High power?
Yeah.
Okay, again,
Okay, so this is...
we are not showing all the stains, but obviously these are B cells.
And yeah, I think you can see even at this power a little bit of plasmacytoid differentiation here, but I think we have a higher power, and these are more lymphocytic at the bottom. This again, I don't think the preservation was particular. You see, these are the plasma cells here. You have a follicular structure that if you look on Kappa and Lambda, you see
it expresses the mixed chains. Yeah. So that's why, people were saying ratio 4:1, but I think if you look now at the microenvironment, you can rationalize and you can interpret the signals.
Yeah. And the reason why I'm saying is probably in the smaller cells, the signals are not in the lymphoid cells. So we see a lot in the plasma. It's possible that most of them have plasmacytoid differentiation here.
Yeah. But so far, apart from the convenience of having one stain, both probes in the same slide, so far, this is not great advance for the traditional in situ hybridization for Kappa and Lambda that has low sensitivity. Because we would have picked up these signals in these cells is quite strong. So
in plasma cells, yeah.
So I wonder whether you will show us some cases where...
Yeah, but I think it's still useful to have the same,
It's nice. It's nice to have it on the same, but I think this must be another case of strong staining. But hopefully we will see some cases where the signal is not so strong, and that would not be a signal that you could pick up by the conventional in situ hybridization. And as we discussed before, is a signal that is difficult to interpret with antibody. So that's where I think the high sensitivity really comes to place. Again, this is an infiltrate where maybe there are still some reactive aggregates, but this is quite monotonous. It has effaced the adipose tissue. It kind of spares the epidermis, as you can see there.
I think this was the 75-year-old man which had a history.
Right.
So he has a lot of solar elastosis. It was on the back.
Yeah.
And here the cytology is overtly worrying.
Yes.
We do have a few lymphocytes admixed in this
small cells, lesion, but these are all intermediate cells of
at least too high. Yeah. And so this is not the case to illustrate what you're saying, but we have other more. So this patient actually had a history of large B-cell lymphoma in the past, and now he had this skin lesion on the back. And Corrado points. Yeah. And I think in these, I found that the range of expression of the signal is relatively wide, but we often get at least focally high levels in diffuse large B-cell lymphoma.
But we have a comment here, just to make sure that no one gets confused. is which one is magenta and which one is black again? And
About-
how do you remember which one is what?
So the way I remember is that magenta is the weak link for me. Silver is the strong one, and silver is been given to the least representative, which is lambda. Lambda is the minority, and
But-
it gets the best,
but stronger.
the best chance to show up. And magenta instead is. What is your way of remembering?
I have a way.
Can
Can I give the way? Yeah, because for me, I always made mistakes. So I don't use magenta, I use pink. So kappa is pink, lambda is black.
And black because also has a kappa.
There is a B, there is a B.
But there is a K at the end, like
No,
pink and black. But that's okay. It's a very good French reasoning. We like that. But what about pink? Can I say that?
Why not?
Pink is for girls and black is for boys. But I don't know how this links to Kappa Lambda.
Are you going to say pink is weaker?
Biggest link? No. Okay. I don't know. Maybe we should put something by the microscope that say kappa equals pink, whatever. Okay. Okay. Is this is more skin? They're all skins, Adet.
I'm just looking at.
You're a dermatopathologist. We have
God.
yes, 20 minutes. We're good.
Yeah, so this is sort of a similar case. I just thought the cytology is more typical in this case.
Yeah.
So
Here is a less intense signal.
so the cells are really small to medium size and a little bit histiocytoid, which is very typical for the primary follicular central lymphoma, and we can see is all kappa expressing.
And you can see actually this is a nice photograph to pause a little bit. You see there is no signal in the interstitium. It's a clean reaction, and you can actually see that you can paint even cells that have very, very little cytoplasm around it. You can paint little dots of the magenta.
I think this is what you would like to see. Maybe not quite this, but you would like to see in the small amount of cytoplasm around the nucleus.
Very nice.
In these small cells. So this is a good example of labeling.
So far, we haven't really seen any of these cross-reactivity with IGL5.
There are many cases.
There are many cases. Okay.
We can go there. Well, this is your
so-
special case.
Is it mine? Maybe.
Yeah. So
With the nodular.
we look at it, and at first glance we say, could this be a lymph node? But it was actually a tumor that was in the dermis and subcutaneous tissue and the abdominal wall. And then it does have this nodularity, but as we look carefully.
What are these pale areas?
So, well, we need to go a higher power.
Uh-huh.
So this is the edge of it to show that it's not a lymph node, but it's actually going, these are the dermal fibers. So it's actually percolating through the dermis. And these are very small plasma cells.
Yes.
So you will look at them and you think these are entirely benign. Maybe they're a little bit hyperchromatic.
Okay.
And this is, well, what I wanted to say is that this nodularity, if you look carefully, is not all lymphoid follicles. So you have, here could be a preserved lymphoid follicle.
Lymphoid follicle, yeah.
But then there is some sort of nodularity with pale centers that is not really typical, and we need to go a higher. I thought I had a few.
That was a nice picture of relatively high power. Or was it this one here?
Yeah.
Because it shows that there are lymphoid follicles. This must be residual lymphoid follicles. So you have a signal for both cells.
But at this magnification, it still looks like we have, it's predominantly kappa, right? Red, pink, magenta.
Magenta. Yes.
I'm colorblind slightly, so I call it red. And then you also have silver signals.
Yes.
So I think
have
we
you
need
got
to
high
look
power on that?
at.
Yes.
So this is an area that has more lymphoid morphology. So it's very uniform, small lymphoid cells, atypical. I'm not 100% sure. And
what? So these are the cells in the background, yes?
yeah, I think it's a lot of red, a lot of
It's fine red granules.
Kappa.
Yeah.
But then you've got slightly larger cells that have, in the cytoplasm, they have Kappa, and over the nucleus, whether it's here or here, they have lambda. And then there are cells, but not very many, that have
a big
lambda in the cytoplasm, perhaps. Perhaps. And this is another area. I wish I have taken a higher power picture. I don't know if I have another one, but these are more plasmacytoid cells that have much more signal. And if you look at each one of them, they're all actually Kappa.
They're all
because
magenta.
they have
Yes.
magenta in the cytoplasm, but the nucleus is black.
So is this the cross-reactivity with?
We thought is IGLL5.
5. Yeah. Okay.
No. Next.
An axillary node.
Yeah.
Oh, I thought we didn't show lymph nodes, but that's good. Well, to me, it looks like CLL.
Well, if you say so, it has quite a nodular appearance.
It looks like bloated, hasn't gone out of the higher power. I don't know. It could be something else. This could be still preserved B-cell areas, and this could be proliferation centers, or
it looks like, there's a bit of
follicular lymphoma, but
interstitial nodules. Yeah. Follicular lymphoma is another
diagnosis, and these are pale areas. This could be a residual follicle.
Yeah.
Okay, let's see the staining. So here is predominantly magenta.
Yeah.
And you can see the fine staining. These are no longer here. There are those very dominant plasmacytic-like.
So these are small lymphocytic cells. So this is actually the cell, the small CLL cell that is quite difficult to see from this point of view.
Nice.
Because
yes, this is nice. Very small amount of cytoplasm. They're all close to each other.
The cells, looking at them, and you can have even more subtle, let's say, interstitial growth of this.
I mean, of course, nobody needs Kappa Lambda to diagnose CLL. It's obvious, no?
Well,
but I think these exemplify the fact that if you have a small lymphocytic type of lymphoma of some sort with very little cytoplasm, you still get a lot of signal, and you can understand whether there is monotypic.
The problem is, even in CLL, just like in marginal, sometimes the other immuno doesn't help you as much. Of course, the patient would be known with this.
You will get a peripheral blood. There are other way of exploring these things. So this
particular case can be difficult.
Yes, this particular case may not really present any clinical challenges after all. I mean, but I find that the marginals do present a lot of challenge, because you never really manage to get a full diagnosis of marginal zone lymphoma.
Like in the previous case, because here, while in this one, we've had some immuno, there's no marker to tell you this is marginal zone lymphoma. And then if it's not atypical.
Okay, so the other area where there is a great applicability of this is of course GI biopsies, where again it's a small sample. You have a warring population that stains in a way that makes you suspect that perhaps there is
I do have a slide of that I can show in a GI, but it's only the Kappa Lambda because
don't worry, but I think and possibly there may be some examples in the circulation that we opened today. So I think yes, it's useful in general in lymphoreticular pathology. I think where it shines a lot is in skin and GI, because
but also we need to think about that sometimes we get small biopsies from the lymph nodes, which are sometimes a bit more difficult to
the core
understand
biopsies.
the
Yes,
core biopsies of the
because
node, because
now everybody does core biopsies rather than excision.
and
Yeah.
it's more challenging if they're outside the hematopathology. So it's for the kind of the wide,
Yes, I
let's
mean,
say,
yeah.
workup in different services. Like, for instance, with us for breast cancer, we get lymph node biopsies from the
Yes,
axilla.
and every now and again you feel you really would like to be reassured that you are not overlooking a lymphoma. So that could be, you know, a good reason. So maybe the professional lymphoreticular pathologist may or may not find these tools very useful.
I think they're less useful than for us, for the general pathologist.
Okay, so this is the end of the presentation. Emilia was keeping track of comments, and incredibly, she hasn't interrupted us many times, so she wasn't objecting to.
There is one more comment where Dr. Stetson proposes to use IRTA for marginal zone lymphomas.
Yes.
As a comment, yeah.
Yeah, absolutely.
But apart from that, we haven't had many questions. I do have a question, though, to the audience. Has anyone tried this Kappa Lambda dualish? You can raise your hand or you can post it in the chat.
Okay. Yeah. So, you know, Emilia, at the very beginning, I said that, and the reality is there are many kits available for you to do this, but in reality, we've never really managed to put anything in to work in the laboratory. And I have to say, when this came out, we got a couple of boxes, we started to play with it, and in no time, we had slides that were very interpretable, and we started to understand how to interpret the actual stain. So I think the great advantage of this is there is good support. I have to say good support, and it seems to be now a very robust tool, although our experience is still limited.
Yeah. We did this also, we run it on cases that were already diagnosed by other means. So, you know, we had an idea how it works and if it correlates to the Kappa Lambda-ish that we were doing with the silver probe on 2 different slides. And we had a lot of reassurance from that.
Is anybody telling us that they've already tried?
One, yes, Dr. Einden and Petraki tried it. So this is, and myself, I'm really excited about this because I'm not a heme pathologist. I do solid tumors mainly, and I always struggle with the IHC and send for referral if ever I suspected something. So with this, I feel that, you know, I can select the cases I send further for sub-classification as not being an expert in it. But I was, you know, with IHC, I needed to send much more.
That's a great point, yeah, because we sometimes struggle with the biopsies, whether they're from the breast, from the skin, from GI, and then we need to understand.
So very good. So, you know, we can leave the discussion open for a little while, but it's good that we, for once, finish in good time. I hope next time we'll bring you some other cases that are interesting from the GI tract, which is my other main preoccupation. I wanted to remind you that the circulation is open today and will close in a fortnight, and then we'll have a feedback meeting on the 10th of December at the same time, 3 o'clock. And I do hope that Teresa is going to be well and she'll participate in the discussion because she has a wealth of experience. And in fact, she was one of the original pathologists that contributed to that publication I showed you from 2014. So thank you very much for listening, and we'll see you in a fortnight. Thank you, Emilia.
And thank you for a great presentation. And to everyone else, thank you for participating. And don't forget to try it out yourself on the cases. Yeah,
easy cases. So it would be just a delight to do them. And we see more interesting ones during the feedback.
Yes,
hopefully.
we'll also show some other cases in a fortnight.